Welcome back. This is part 2 of the chapter on the kidneys, chapter 12. We had just finished summarizing the 4 steps of renal processing, filtration, reabsorption, secretion, and excretion. And we are moving on to how we assess kidney function. In order to understand some of the measures, I have to explain a little bit about where some stuff comes from. So here's some background information about protein metabolism and urea and where that comes from. So over on the left, and I took these images also from that video that I mentioned before, the crash course video. So you'll remember proteins are large macromolecules. They're made of smaller units called amino acids. Amino acids are called that because they have the so-called amine group. It's a nitrogen with a couple of hydrogens stuck on it. If we use the protein that we eat, if we use that protein for building some more muscle or for, I don't know, making hemoglobin or for making something, that amine group stays right where it is. But if we use the protein either for fuel right away, or we use it to make some sugars. Believe it or not, you can convert proteins into carbohydrates, or we convert it into into lipids to store in adipose tissue. If those things happen, then we have to take this amine group off. And that's got to go somewhere. And the process of taking it off happens in the liver. Let's see, made amino acids. Okay, so in the liver, the amino group is removed. When you take that off, it forms ammonia. This is bad news for the body. It's especially bad for the nervous system. And you will have patients whose liver is malfunctioning and that it's not able to get rid of this ammonia. It's really hard on the nervous system, as you will find. So what the liver does, instead of leaving all this toxic ammonia hanging around, it puts 2 ammonias together and it forms a molecule known as urea. This is a lot less toxic than ammonia, but it's still a waste product. We still need to get rid of it. So it gets out into the bloodstream, and then the kidneys are going to get rid of it. When we measure how much urea is in the blood, it's referred to as blood urea nitrogen. Not quite sure why they don't just call it urea, but it's not. It's called blood urea nitrogen. Okay, the other waste product that we keep track of is something called creatinine, and it confuses everybody. Creatinine is not poison. It's just that it's a really good marker for how well the kidneys are functioning. So let's talk a little bit about where it comes from. There is a molecule called creatine. Creatine, in fact, some people take it as a supplement. What its job is, it can hold on to a phosphate group. And you remember when you put a phosphate group on something, you phosphorylate it. It's a way of increasing the energy of this molecule. And so, for example, we use ATP to pay for stuff like the sodium potassium pump. We have to pay it. So we pay it with ATP. We put that phosphate group on to the sodium potassium ATPase to get it to pump some sodium and potassium. Well, how do you get the phosphate group on the ATP in the first place? Well, you put it on during phosphorylation over in the mitochondria. Sometimes you need to recycle this ADP, adenosine diphosphate. You need to recycle it back into ATP really fast. And you don't want ADP to ever have to be waiting for a phosphate group. And so that's the role that creatine and creatine phosphate play. is as soon as we use up the ATP, use it to pay for something, the ADP can get back to the mitochondria and get another phosphate group put on it really fast. Doesn't have to wait for it. So if you had all the time in the world, ADP would get its phosphate group, it's going to happen. But in those cases where you need a lot of this ADP recycled quickly, that's the huge advantage of creatine and creatine phosphate, is that it slams that extra phosphate group back on the ADP, making ATP really, really fast. And so the people who take creatine phosphate are folks who do explosive kinds of movements. So athletes that need a lot of power really fast, like, for example, football players, baseball players, weightlifters. When you're going to use a lot of muscles and you need those muscles to contract very quickly. We've gone over muscle contraction before, and when, the calcium movement and the myosin and the actin and all of that, that's using a huge amount of ATP, and you want to replace that really, really fast. That's where the creatine is so beneficial. Athletes that don't benefit from this are things like, I was going to say chronic, oh my gosh, what is it called? Long distance runners, long distance swimmers, people who are they're exercising, they're using their muscles, but they don't need all the ATP all at once right now. There's time. And so there's not a huge benefit to taking creatine. But all of our muscles, athletes or non-athletes, all of us have creatine in our muscles, and its role is this, to put that phosphate group back on the ATP when we need it quickly. If you need an analogy for understanding this, I think about fashion shows when you have models walking on the catwalk and then they come back, and then it seems like 10 seconds later they walk back out again and they have a whole new outfit on. They didn't do that by themselves. There's a bunch of people backstage that are helping with the removing of the clothes. They could change their own clothes. They know how to do it. They've got the capacity to do it. They just can't do it that fast. And so that's where the helpers come in, trying to do the turnaround faster. And that's where creatine comes in. And so it's a natural compound. It's present in all of our muscles. And some of it breaks down every day. And so let's see, over here on the right, we have creatine. This is the molecule as it's functioning in the muscle. It becomes creatine phosphate with that extra phosphate group that it can slam onto an ADP. But it'll sometimes break down to creatinine. This is not useful. This creatinine is not able to do this job. And so this is just a waste product. It's just a small percentage of the creatine becomes creatinine every day. So creatine, it's the functional molecule. It speeds up making ATP, and the creatinine is just the used up version, and it's a waste product. It's just that it's an easy waste product to keep track of. If you need another way of thinking about it, as far as this waste goes, I think about it as it's eggshells, for example. It's just trash. It's not super dangerous, but if I have a way of assessing eggshells, if I could just feel through the garbage bags in my house and I couldn't see anything and I couldn't measure anything else, I could just feel the cracking of the eggshells. Okay, I can detect that. That's how I'm going to keep track of, say, how often the trash is being removed, or if I'm getting a buildup of trash in my house. It's not that the eggshells are super important. It's just that there's something that can be detected and measured and kept track of. That's all the creatinine is. So measuring kidney function. One of the measures that we're most interested in is how much fluid is passing through the glomeruli. That's known as the glomerular filtration rate. And ideally, there would be some magical way where we could, monitor each and every one of the glomeruli all day long and just see how much stuff is flowing through there. There is no way to measure that carefully, that directly. And so we assess it mostly as an estimate. So usually GFR, you'll see a little letter E in front of it. It means estimated. And we can estimate it using some kind of marker, something that's already in the blood. And that's what endogenous means, something that's already in our bodies. What's usually used as the marker is creatinine. And it's not urea. You might think it would be urea, but it turns out urea varies too much. I mean, yes, it varies with kidney function, but it can also vary with other things, like how much protein did you take in, and how much are you using for fuel, and how much are you using to store, how much are you using to build. So it's not urea is not a great consistent measurement for this. That's why we use creatinine. But again, think eggshells. It's just a waste product that we can keep track of. If there's some reason that you absolutely need a better estimate of the glomerular filtration rate, then instead of relying on some endogenous marker that's going to vary depending on how muscular somebody is and how much exercise they're getting, let's use an actual measurement. In that case, we use an exogenous marker, something that's actually infused into the patient. We know exactly how much we're giving you. We can test how much is in your blood, and then we can watch how much is coming out. And we can watch what's happening to the blood level of this thing. That's what we mean by measured rather than estimated. This is typically not done. We just usually do an estimated glomerular filtration rate, and we usually use creatinine to do this estimate. So it represents the total amount of filtration that's occurring. In other words, the sum of all the filtration that's happening in all of the nephrons. As nephrons decline in function, if they're damaged or if the cells are dying off due to kidney disease, that glomerular filtration rate is going to come down and down and down. Then there's this other measurement. This is known as the renal clearance rate. It's not the same thing as the glomerular filtration rate, but it's what the estimated glomerular filtration rate is based on. So instead of estimating total filtration, how much stuff is going through the kidneys, it's looking at how efficiently are the kidneys removing a specific thing. In other words, in 1 minute, how much blood can be completely cleared of a certain substance? Okay, now some things should have zero clearance. We should not be clearing them at all. A couple of examples, small nutrients, things like glucose, small six-sided sugar, and amino acids. Those are the building blocks of the proteins, but they're not proteins themselves. There's the smaller bits that make up the proteins. Those things are small enough that they slip through the glomerulus. They just slip out into the filtrate. So they're filtered out because they're so small, but then we pull those back in, we reabsorb those. I'm going to do an aside here. If we start detecting glucose in the urine, that is a sign that the patient is diabetic. Because if the blood glucose level is under 180 milligrams per deciliter, and that's super high, but if the number is under that, the kidneys can manage to pull the glucose, all the glucose back in. This is going to come up later in the lecture when we talk about a particular medication that has an impact on the kidneys. So glucose, under normal circumstances, glucose and amino acids, they get filtered out because they're little, but they're valuable stuff. And so we pull them back in through reabsorption. So we did zero clearance. We shouldn't see either of those things in the urine. And likewise, large proteins, we shouldn't see those in the urine either, but those shouldn't even be filtered out. Things like albumin, which is the most prevalent protein in the blood, the clotting factors, the complement proteins, none of that stuff should be coming out in the filtrate. On the other hand, some things like creatinine, they have great clearance, very high clearance. One, creatinine gets filtered out in that first step, and then it's not reabsorbed because we don't want that. That's a waste product. And then on top of that, we do some more secretion. We actively push it out of the blood and put it into the filtrate. So creatinine clearance is so good that that is the molecule that we typically use to estimate the glomerular filtration rate. And there are formulas that you can use to estimate glomerular filtration rate, and you take into consideration things like how old is the patient, and that's related to how much muscle mass do we think they have, and whether they're male or female. All right, the units, if we're estimating it at the milliliters per minute, if we're measuring it, like you have to do a 24-hour urine collection because we want to get every molecule of creatinine that this patient is peeing out. It requires a strict 24-hour urine collection. A little bit more about renal clearance and drug dosing. So our textbook goes in a little bit about the antibiotics. So penicillin and many of the antibiotics, they actually have high clearance. They get filtered out unless they're bound to proteins. So some formulations of some drugs are actually designed this way. So the medication actually doesn't need to work. It doesn't need to be attached to a protein. But if we don't make it attached to a protein, it's going to just come out from the glomerulus every time. And so some medications are formulated so they will hold on to, say, albumin. And that way it's harder for the body to get rid of it, so we can have the action of that drug longer. But many of the medications, even though they're not being filtered, they're still actively secreted by the tubular cells. So when prescribing medications that get cleared by the kidneys, one has to consider the glomerular filtration rate. In other words, consider the health of the patient's kidneys, because if the kidneys are not working well, they're not going to filter the medication out. And so we're going to get delayed drug clearance, which again sounds like, oh, that's good. We're going to get more bang for our buck. Well, a little bit of medication and it lasts a long time. But if you dose them the same way you do somebody with healthy kidneys, then the medications can build up to toxic levels. And so with our older patients, a little medication goes a long way. We have to keep track of which medications are cleared by the kidneys. All right, so injuries, glomerular injuries and disorders. The capillaries, the glomerular capillaries are vulnerable to damage. And these are some of the sources of the damage. Diabetes, one of the worst, the uncontrolled diabetes, when the blood glucose is so high, the patients with chronically high blood sugar, they end up suffering from what's known as diabetic nephropathy. You know, with the A1C test, you know that glucose binds to the hemoglobin. That's how the A1C test works, is you're basically saying how much of the hemoglobin has glucose bound to it. Well, glucose binds to other proteins too. And unlike the red blood cells that get replaced all the time, our other cells aren't being replaced. And so this glucose protein binding, this glycated protein formation, it leads to inflammation, it leads to fibrosis. And so initially what we get is a breakdown in that barrier. And so where before proteins were not filtering out, now this barrier is breaking down, and so it's got big old holes in it, and protein can slip out. And so when we see protein in the urine, proteinuria, that's a sign that there's damage in the glomerulus. Ultimately, this is going to lead to fibrosis, and then we're not going to get even little things filtered out. That's chronic kidney disease. The other thing that we see commonly in the clinical setting that causes damage to the glomeruli is hypertension. So it's damaging the afferent and efferent arterioles. promoting atherosclerosis. That's going to narrow the lumen of these, some of the blood vessels. So we're decreasing blood flow is one of the things that happens. But with the elevated blood pressure, especially elevated above a certain level, actually coincidentally, it's also 180, elevated above that level, we get hyperfiltration. So you're pushing more fluid through. The tubules are overloaded. So the closet analogy, we dump out more than 20% of what was in there. Just more stuff comes out. And the tubules get overloaded initially. But again, this leads to damage of the glomeruli and chronic kidney disease. There are some infections that, of course, can have an impact on glomerular functioning, a kidney infection. And there are autoimmune problems that can happen. And we're going to continue this on the next slide. When we have immune-mediated glomerular damage, we get this inflammation within the glomeruli. We call that glomerulonephritis. And what happens, you remember that there are antibodies, our B cells matured into plasma cells, and they've been a bunch of antibodies, or antibody-antigen complexes. The antibodies have already attached to something else, but they're in the bloodstream, right? So they go through the glomeruli. Well, some of those things kind of stick, deposit in the glomeruli. That can activate the complement cascade. That draws in lymphocytes, monocytes, neutrophils recruited to the area, more inflammation. The glomeruli get damaged. We get swelling of the cells. This blocks flow through the capillaries. Glomerular filtration rate goes down. Sometimes we will see a very acute presentation of these symptoms. The one that's most famous is the strep throat, post-strep throat, or Streptococcus pyogenes. You may remember this from the first module when we did the infectious diseases. Strep is famous for this. It doesn't happen to everybody who has had a strep infection, but it does happen, and it happens especially commonly in children. So sometimes children present with all these, kidney problems that they've never had before. And in getting the history from the family, we find out that the kid recently had a strep infection, or they're currently having a strep infection. We can also see chronic problems with the autoimmune system, with the immune system, in the case of autoimmune conditions like lupus, for example. This can result in chronic kidney damage. Some of the symptoms that we see on the urinary side of things: decrease in urine production, protein in the urine. Remember, the filtration mesh got big openings in it. It may get so big that you actually get red blood cells coming out. Hematuria. Red blood cell casts. Okay, this is a difficult concept for me as a student to understand. I thought, well, what's the difference between hematuria and red blood cell casts? And it's the difference, more analogies, in your house, sometimes there's dirt on the floor. And you think, where did this dirt come from? Well, if it's all dusty, little dusty particles, you don't know, that may have just washed in or blown in, because the door was open or the windows were open and some stuff blew in. But if it comes out in like a little square, there's some weird little shape of dirt, that's from a boot. That's like mud that got into a boot. It's got a particular shape to it, and it just fell out of the boot's tread onto your floor. That's what a cast is. It's dirt in a particular shape. And so it's a cast of the nephrons. And so if you have a bunch of cells that are kind of stuck together with protein, that's coming out of the nephrons. That means there's some damage up above it. This blood is not from, say, a bladder infection. This is coming up from the kidneys, or coming down from the kidneys. And then the dark tea-colored urine, again, sign that you have some blood in the urine. Systemic manifestations, blood tests, azotemia. So emia means in the blood. Azo it refers to nitrogen. And I can tell you the history about it if you're interested, but azo just refers to nitrogen. And so it's an indication that there's going to be some increase in a nitrogen measure. Blood urea nitrogen, serum creatinine. Because the kidneys are not working well to get rid of, they're not filtering well, they're not getting rid of a lot of water, we get the retention of the water. And so we may see hypertension, we may see an increase in blood pressure because more fluid is staying inside the circulatory system. Again, more fluid, we got fluid overload, we're going to get edema. Increased pressure in the capillaries is going to push some of that fluid out into the tissues. So edema of the face, upper extremities. In children, you might even see ascites, swelling in the abdomen, and fatigue. All right, blood to the kidneys, renal blood flow. You'll see this abbreviated sometime as RBF, like here, for example. So kidney vasculature can dilate or constrict. Those afferent arterioles, they can shut down or open up to maintain a steady flow of blood through the glomeruli. So even when the blood pressure varies, this is known as autoregulation because the kidneys themselves are taking care of this step. So let's walk through this graph. On the x-axis, we have arterial blood pressure. So normal, these ranges, well, I shouldn't say normal, typical. Down here, if the blood pressure is too low, and I'm sorry, I'm just looking at the blue line, I should not. If we're looking at arterial blood pressure, we have, actually doesn't matter. We have low blood pressure here. If the blood pressure is very low, we're not going to be able to perfuse the kidneys adequately. But within the normal limits of blood pressure, you can go up or you can come back down, and that the kidneys are just really good at this. You know, they just regulate how much blood they're going to let through. And so if the kidneys are able to dilate the blood vessels or constrict the blood vessels, they're able to maintain this steady renal blood flow no matter what's happening out in the systemic circulation. Blood pressure may go up because the person's stressed, or may go down because whatever reason it goes down. But the glomerular filtration rate stays steady as well. And it's because the renal blood flow is kept so steady. Above a certain level, above 180, the renal blood flow increases. There's no way around, and that's where some of the damage comes from. Now, in cases of extreme hypotension, oops, oh my goodness, where are we? In cases of extreme hypotension, we're way down here. Yeah, the kidneys get overridden. So in extreme hypotension, the sympathetic nervous system can override the kidneys. The kidneys are saying, oh, I'm going to dilate and let more blood in. And the sympathetic nervous system says, no, you're not. You're going to clamp down. Because we need that blood to get up to the brain, and we need it for the heart. And so if this is a short-term thing, it causes a transient decrease in glomerular filtration rate and a transient decrease in kidney function, then great, the kidney can recover. But if this hypotensive state goes on for hours, the kidneys can develop a problem. As we'll define shortly, there are pre-renal, intrarenal, and post-renal causes of kidney failure. This refers to a pre-renal cause of renal failure, and that is the blood supply to the kidney. So pre-renal failure, it's not pre-failure, it's pre-renal, something coming to the kidney due to lack of perfusion. All right, nephron tubular function. Each part of the nephrons do something. They have characteristic roles. We've mentioned this repeatedly. More than 99% of the glomerular filtrate gets pulled back in. So what we end up releasing as urine is it's a small fraction of what originally became filtrate at some point. We're going to look at the different parts. Proximal tubule, we get lots of reabsorption, we get some secretion. Loop of Henle, we get reabsorption of water and sodium and chloride. Distal tubule, we get some reabsorption of these electrolytes, and collecting duct, we do the final regulation, the final fine tuning of things. And let me see. We've gone on for some time, so I'm going to make a decision to call it here. This will be the end of part 2, and I'll see you in part 3 for more of the details.